Okay, so as we look at the kidneys, again, well, let me back up real quick. There you go, Tuesday, December 1st, 2020, urinary system, chapter 25. Let's take a peek now at the four major organs of the urinary system. So we do see more than four on this particular illustration. Our focus is going to be primarily on the kidneys to start with. I think those are pretty evident for all of you. You've certainly heard of the kidneys and possibly knew where they were located, kind of in the middle to lower back in the posterior area, maybe a little bit below, or kind of maybe near the end of the ribs. And so, yep, you'd be exactly right. And they're kind of exposed. We'll see that in just a few minutes. But yeah, the kidneys, these are the primary organs of the urinary system. We see there are two major tubes that come out of each kidney, one left and one right. These are called ureters. Okay, so the ureters are the transportation tubes that are delivering urine from the kidneys down to the urinary bladder. Okay, a lot of times, when someone's passing a kidney stone, the pain occurs from kidney to bladder. Oh man, that's where they'll really feel it, because and then once it's in the bladder, it's it's still gonna hurt, right? But you're gonna know you're gonna be well. There's no amount of preparedness probably for that, but you'll probably feel it, and you may not if it's tiny enough. It could pass all the way from the kidney down to the bladder, and then you may feel it coming out through the urethra. There are and we'll talk about them a little bit next semester, but there are a lot of micro calculi and tiny stones as well that may only show up in like a urinalysis. So the patient may have things in their urine that they don't feel, solids in their urine that they don't feel when they're passing the urine. Yep. Good. Yep. So the kidneys now, they're technically, as far as like the abdominal quadrants. So generally, the kidneys are considered to be retroperitoneal, which means they're kind of behind the abdominal cavity. So I've got a slide here that'll show that a little bit better. So we look at a bird's eye view. This would be the lower illustration here. This is the anterior portion. And again, this is going to be a transverse or a horizontal cut. And we're going to see done through the abdominal region. It looks like it's right about halfway through the kidneys. So what we see is the abdominal cavity. Here they're calling it the peritoneal cavity as well. And last time we were together on Tuesday, we looked at the parietal peritoneum a little bit and the mesentery, and basically that covering of the abdominal viscera. Now, the kidneys are behind or kind of outside of that abdominal cavity. And so when it comes to looking at the abdominal quadrants, the kidneys generally aren't considered. They're considered to be retroperitoneal, or kind of behind the abdominal area. But if we did, we would have the right upper quadrant and the left upper quadrant for the location of those kidneys. Yep, absolutely. And then as the ureters dump into the urinary bladder, that's our third stop. And then our last, our fourth structure is called the urethra. And so we'll look at the urethra differences here in just a few minutes that we find between male and female urinary systems. Now, so the whole thing, these four items are the urinary system. Now, the tubes, so going from ureter into the bladder and then out through the urethra, that's going to be considered the urinary tract as well. So some of you, probably all of you, have heard of a urinary tract infection or a UTI. And again, I want to emphasize that it's a T at the end of tract, not a K. So it's TRACT, tract. And again, this would be at least the third week or the third body system we've seen some sort of tract. We saw it with the respiratory tract, then the digestive tract, and now the urinary tract. And we'll see it again on Thursday with the reproductive tract. So a tract implies that we have some sort of tube going. And these tubes are going to be just like we saw last week and the week before. These tracts or these tubes are going to have a lumen, some sort of the space that the fluid or the substance is passing through, and then we're going to have the lining. That's going to be epithelial in origin, and then some connective tissue, and then that smooth muscle layer. So and then keep continuing out, we'd have more connective tissue, more epithelium, and then we would be part of the peritoneum if we're talking about the ureters and the urinary bladder. So there would be the superficial kind of covering of these of the ureters and urinary bladder are going to be connected with that parietal peritoneum, which you'll recall was that epithelial connective covering of the abdominal viscera. So the abdominal viscera and the digestive tract are intrinsically linked to the urinary tract via that peritoneum. And that can come into play here in a little bit when we discuss UTIs in more detail. So anyway, that's what we have going on with the urinary system. At least on the surface. We do need to dig a little bit deeper into the kidneys, and then we also need to look a little bit deeper at these tubes or the urinary tract itself. Now, before we move on from this slide, I do want to mention a couple other items that we've seen in the past. We do see the adrenal glands. Ad, of course, means toward, and then renal means kidneys. So adrenal. And then, so this would be where adrenaline comes from. We saw several that we broke down the adrenal gland into sections. We looked at the outer cortex and then the medulla. So we saw a lot of your corticosteroids and mineral corticoids and some other hormones coming from the adrenal glands. So they're intrinsically linked with the kidneys. So there is definitely a connection there. And again, in physiology next semester, we'll talk about some of the renin, angiotensin pathways and the aldosterone pathways that all relate to stress and the kidneys and fluid balance. And so we'll revisit adrenal kidney connection in more detail next semester. The other things that we see certainly are the bright red and bright blue of the indicative of the cardiovascular system. We see the renal artery coming off of the abdominal aorta or the descending aorta. It's so dry. My dehumidifier, I think, is as low as it's been. I think it's at 21 or 22% right now. Unbelievable. So anyhow, so my water may dehydrate, the rest of my glass may be dehydrated to dry up before we get out of here tonight. Lucky I've got that big that 2.5 gallon tank over here. So anyway, the renal artery going in, renal vein coming out. Now, pretty straightforward at this point. I don't think up to now anything we've done or talked about is that mind-blowing or that difficult to grasp. I think you guys all know the kidneys already. We're just going to add ureters to the bladder, which you already know about the urinary bladder, and then one urethra, which is going to be the delivery tube out of the body. All right, and then we've got to give the kidneys blood to be able to filter and to regulate. So that's going to come off of the aorta and into that renal artery. All right, and then the adrenal glands, of course, as well. So this slide we looked at a few minutes ago. Again, we'll look at letter B in just a second. But again, I want to reemphasize that the kidneys are in a body position that's called retro, like going back, retroperitoneal. So that's the type of question that I've seen on the T's. I've seen it in NCLEXs, is the kidneys are located A, um, peritoneal, B, thoracic, C, retroperitoneal. So that's what you're looking for, retroperitoneal. Retro means behind. So they're behind or outside of that peritoneum. Okay. Let's see what else about this. We'll move over to up to this one. Kidneys generally, right and left kidneys are roughly the same size. There's not a lot of difference in size for the most part. We do see the right kidney a little bit lower than the left kidney. Not exactly sure why that's the case, other than we do have the sigmoid, kind of on the left side, the lower left quadrant going back into the abdominal region. We do have the descending colon, and then kind of a dipsy doodle with that sigmoid colon as we head over to the rectum. So yeah, there's a little bit more space maybe taken up by that area, but we do see the left kidney slightly more superior than the right kidney. I'm not even sure if this makes it seem pretty dramatic. I think the difference, I wouldn't say it's quite this dramatic for most of us, but there is a slight elevation usually of the left kidney relative to the right. Okay, so a couple other items of interest. You definitely know what a kidney looks like. It's oval, like a kidney bean shaped. The other thing too about the kidneys, because they are retroperitoneal, they do need a little more protection. So we see what's called a fat capsule or a fatty. They call it a renal fat capsule or renal fat pad. So in essence, the kidneys are encased in a fatty kind of shell. All right. So let's go inside of the kidneys. We're going to add, so up to this point, your major terms are kidneys. So know the path of urine on the macro scale: kidneys, ureters, urinary bladder, and then urethra. So boom, 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 and out. So now we're going to go a little bit deeper into the kidney, and then we're going to go even a little bit deeper yet. So, but anyhow, we're going to do a frontal or coronal section of the kidney. We'll come down to the ureter and work our way in, and then we're going to come and we're going to come all the way back out and then work back towards the ureter. But I did want to bring up kind of to give you kind of a spatial arrangement of where we're located. But also, I wanted to mention this term again, hilum. We've seen that with the respiratory system, where the pulmonary arteries, veins, bronchi, that whole area where all the action goes into and out of the lungs. We see the same thing. We saw it with the spleen. We saw it with the lymph node, where you have this kind of region where everything is coming into or leaving the organ. So for this spot, it's a kidney. It's still a hilum. So what we don't show here, and for good reason, because our emphasis and focus right now is not on the vascularization of the kidney, but we don't see the renal artery and renal vein here. Now, normally we would, and here we go, just for perspective. Here's the ureter, renal vein, renal arteries, all going in or leaving the kidney in the same area. That is called the hilum. All right, so let's go back and focus now on the kidney itself. So we have again a frontal or coronal section. We divide the kidney first up, just like we did the adrenal gland. We look at the outer shell is called the cortex, or the outer region is called the cortex, and then the inner region is called the medulla. So cortex, medulla. Again, at this point, hopefully by now and in this course, you've seen the words cortex and medulla enough times to grasp that cortex means the outer Medulla means the inner. Okay, so superficial, deep. I should probably a better way of saying it. You know those terms now too, superficial and deep. So the cortex is always superficial to the medulla. All right, so and we can call this the cortical region or the medullary region. So they, we can make them adjectives as well. All right, so we look at the cortex, we can see there's some little red circles. These are going to be, it's going to be indicative of vascularization. One thing we can guarantee, there's a lot of vascularization within the kidneys. So we'll see that in more detail in just a couple of minutes. Okay, but that's the cortex. Now the bulk, by the way, too, the functional units of the kidneys are a whole nother batch of anatomy coming up here in a few more slides. So we give you the four basic aspects. Now we're going to give you a couple more aspects inside of the kidney. And then the reason I'm mentioning it now is because the bulk of what we call the nephron, and we'll see it again later, the nephron is the functional unit. The bulk of the nephron is going to be found in the cortex. So keep that in mind. When we get to the nephron, I'm going to mention cortex again, so you'll be able to visualize all of this all of this tissue, and if we looked at it on a micro level, would be filled with nephrons. Okay, those are the functional units of kidneys. Now, these interlobular arteries are going to be helping with, again, some of the delivery of the blood from the renal artery. There's a lot of segments and branches till we get to the interlobular arteries and ultimately to the nephron. So we'll go through that in more detail again in just a couple minutes. But anyway, I'm going to leave the cortex and travel into the medulla. The medulla on the on the gross level, right? The macro level, when we look at the kidney, the medullary aspect is much more dynamic, right? There's we look at the cortex, it doesn't look like there's much going on here. It's just kind of this whitish gray color. On the macro scale, cortex looks really boring. When we look at the medulla, we see a lot more features, a lot more going on. So that's where we're going to spend the rest of our time really on this slide, is on the medullary aspect. So the first thing you probably notice are these pyramids. We've got these pyramid shaped items. These are called medullary pyramids or renal pyramids. And in between each pyramid, so we're on an adventure to the Mediterranean area. We're in Egypt with the pyramids, and then we're gonna go over to Greece and look at the columns. So we've got columns in between the pyramids. Okay, so renal pyramids, renal columns. All right. Still again in that medullary region. Now, what's going on in these pyramids is we're collecting urine. Okay, so urine is being collected in these renal pyramids, and all of that urine is going into these little cups. Okay, so notice these renal pyramids, the kind of the apex or the points of these pyramids dump into these little cups. All right. Little cups are called minor calyces. All right, little cups. One is called a calyx. So again, when we're dealing with Greek letters, we drop the CES and we add an X. Well, really, so for singular, this would end with an X. Calyx. The reason I say that is because if you were looking at this has happened, that's why I have to bring it up. And in a multiple choice question, it may ask you about the renal pyramids. Urine is collected as it leaves the renal pyramids in which of the following? And it might say minor calyx, Calyx. And nowhere does it say minor calyces. And so students will say, hey, the answer is not, it's none of these. So again, I'm not trying to be tricky. Just letting you know that you're learning foreign languages. One thing you've probably noticed throughout the semester is plurals are oftentimes a lot more complicated than just adding an S on the end of something, right? Or adding an ES on the end. So calyces is another one. We saw it with phalanges, right? Phalanx and phalanges. So that one we dropped the X off of phalanx and added a GES. I don't know, right? Calyces, we dropped the X. So as calyx, we added a CES. Now, again, I know some of you have had med term or medical terminology. This is all old news, but hopefully it's at least somewhat of a review and drive some of that home for the rest of you who haven't had med term. That this is why I make these types of pit stops, because I think it's important, and you'll find it to be important as you go. I had a student one time, mitochondria is the plural. Mitochondria is plural. Mitochondrion, ION, is singular. So that's just another example where it was which of the following is where ATP occur, ATP, which organelle does ATP come from? And one of the options was mitochondrion, not mitochondria. That wasn't on there. And again, it wasn't the same student, by the way. A different one says, again, mitochondria, is this the same thing? It looks like it's the same. Of course it is. One is singular, one is plural. So anyhow, moving on, minor calyx, minor calyces. These are small cups that these renal pyramids are dumping urine into, and then they're going to connect to what we call a big cup, the major calyx. So we're going to have a couple different major calyces, and then all of these major calyces are going to converge and dump into what we call the renal pelvis. Okay, so you see that there, renal pelvis, and then the renal pelvis is then going to become the ureter. So as we leave the kidney through that hilum region, that's when we end up becoming the ureter. All right, so know that path of urine. You already know the big scale, right? It goes from the kidneys to the ureters to the bladder to the urethra. Now we're going to go a little bit further and say, all right, we're going from the cortex into the medullary pyramids, into the minor calyces, into the major calyces, into the renal pelvis, then into the ureter. So instead of saying kidney to ureter, now we can say we're going from the pyramids to the calyces to the pelvis. So if you can get that order, you're golden. Pyramids to calyces to pelvis. And again, you want to remember, though, that there's a minor and a major regarding the calyces. So anyhow, know that order of urine flow. And then we're going to get even deeper. We're going to actually look at the cortical region up close and analyze on the micro scale the formation of urine and the pathway that in which urine is formed. Okay, so we're going to go even further than just renal pyramid. Okay, so we're just backing it up, macro to more, small to then super small, macro to micro. Okay, so you guys hanging in there? Four new terms: kidneys, ureters, bladder, urethra. Now we've got four more new ones, because cortex and medulla aren't new, so I don't count those as new. You do have pyramids, minor calyx, major calyx, renal pelvis. So you got four more new ones. Okay, and two of them are calyx. So really you only have three new terms. Okay. So pyramids, minor calyx, major calyx, pelvis, renal pelvis. All right. This is an actual kidney. So you can see one's an illustration, one is an image. This is the image. You can see the renal columns and the pyramids. Again, not as, you know, slick as that looks. Part of it is because of the slice. This is not a great cut. You can see they didn't, this one's probably almost close to being exactly in half. It may be a little bit anterior, the cut. This one is a little too far anterior, so that's why we're not seeing, you kind of see some of the pyramids disappear. So if they would have done the cut here, you would see something that maybe does look a little bit more like that. But anyhow, one thing we do get though is a pretty good shot of the renal pelvis and these two major calyces. We could also locate a minor calyx just by finding kind of the end of a renal pyramid. So here's the end of here's a pyramid. Here's the end of the pyramid. So this is going to be a minor calyx right in here. And then this is going to be a minor calyx here. And then there's another little one here and another little one here. And again, these big area would be the major calyx, and then renal pelvis. All right. Here's the black and white of it. And if you need to see the black and white, the renal cortex, renal medulla. And then we had the pyramids and then the columns in between the pyramids. And then we ended up in the two calyces and then the renal pelvis. All right, so that's the flow of urine. And now we're into we get into the vascularization aspects. I'm going to come back to this in just a second because I want to continue. I want to get the urine out of here. So we left the renal pelvis, and now we're into the ureter. Again, ureter is a tube extending from kidney down into the urinary bladder. Now we'll see that the ureter looks a lot like this. It's got a small lumen when there's nothing in the ureter, when there's no urine leaving the kidneys. When a little bit of urine's kind of trickling through and leaving the ureters, this will stretch out a little bit. So we'll see some of that, what we call transitional epithelium. So I just wanted to mention that transitional epithelium is what we find in the urinary bladder as well. So the lining of the of the ureters and the urinary bladder is going to be that and the urethra is going to be that transitional epithelium. And again, it allows for expansion, especially when we look at the urinary bladder. Mostly smooth muscle tissue then beneath that transitional epithelium. We see a lot of elastic fibers in the connective tissue layer, and therefore we can distend and stretch the bladder considerably. Couple of things too regarding they have female on the left, male on the right. Now a couple of caveats whenever we start talking about male versus female and anatomical parts and sizes and things like that. I've already, boy, that sounded weird. Well, it's recorded, so you can go back and listen to it, but it really wasn't meant to. Size of a kidney in a male versus size of a kidney in a female, probably, I mean, maybe a little bigger in a male, maybe not. I mean, it's more about body size. You know, if you have an extremely large female and an extremely small male, all bets are off, right? We could say probably deduce that the extremely large females and have bigger kidneys. And I don't mean large like obese large. I mean large in stature, right? Like a 6'4", 200-pound female is going to have bigger kidneys likely than a 5'1", 110-pound male. So that's, I guess, what I'm saying about just generalizing that males have bigger kidneys than females. Not really. I mean, maybe sometimes, right? You get the idea. When it comes to the ureters, it's the same thing. Males' ureters generally may be a little bit longer, but what if I have a really short male and a really tall female? Then I can't say that male ureters are longer than female ureters. So I guess keep that in mind. There is so from kidneys to ureters, the difference between male and female, probably somewhat negligible. All right. When we get to urinary bladder, though, a little bit different. We do see the urinary bladder, the males, the positioning and location and what's around it is different, right? We see over on the female side, we've got the uterus sitting kind of on top of that. And if any of you have had children in your uterus, you know that it's sitting on top of your bladder, right? So anyhow, oh, hold on a sec. I put that on the brakes for a quick second. I'm going to get into the chat. Let's see what's going on here. Do internal organs grow with weight? Not necessarily. Um, um, Organs will become inflamed due to overwork or overuse. So typically, no. An organ now if you're talking about normal growth, right? Like from out of the womb, certainly, right, till you're done growing. Yeah, of course they're growing. You know that. But yeah, I think you mean like if I gain a bunch of weight, right? My normal body type and weight and size is, we'll say, around 200 pounds. um, and I mean, from age probably 16 till up to now, I've pretty much been between 190 and 220 pounds. Okay. Now, if I gain like 75 or 80 pounds, so I go up to say 300 pounds, are my organs going to grow with that? Likely no. I'm probably filling in, unless if it's my skeletal muscles and I'm lifting a bunch of weight, right? Like I could hit the gym and pump up some amino acid shakes and shoot some roids and do the Chris Hemsworth and, pushing big tires around and, getting prepped to be the Hulk Hogan in the next movie, the biopic or the biopic. You know, I could get up to 300 pounds and my muscles, yeah, the skeletal muscles are going to certainly get bigger. Nothing else will along the way. In fact, certain things they say might shrink. Especially with the steroids and the pumping of the iron. I wouldn't know. I don't never did steroids. And anyway, so let's see what's how about obesity? Like I gain like 100 pounds of fat. What happens is that subcutaneous fat, as well as our liver has kind of a fatty capsule around it. Our kidneys have fat capsules that you saw. So we're going to see those adipose, what we call adipocytes or fat cells. They're going to just get filled with potential energy. So fat cells get bigger as we store more energy that isn't burned. So calories in so far exceed calories burned that we just start storing it in our lipid cells or our fat cells. And then, so again, another reason why liposuction is a bad idea, because you're just vacuuming out fat cells. The problem isn't amount of fat cells. Like you don't multiply fat cells if you're getting fatter. You're just adding to the existing cells inner contents. You're adding energy into stored energy into the fat cells. So if I just start sucking out fat cells, now I'm just left with space where fat cells were, and then the fat cells I didn't suck out, they're just going to fill in that space more than likely. So the idea is really to be conscious and aware of caloric intake and then energy expenditure. So just to survive without if you could be pretty sedentary, not burn up a lot of juice, and you live on 700 500 to 1200 calories a day, if you're not really doing much. And again, those are dependent on body types, body sizes. Like I'm 6 foot 200 pounds. If I and I I'm not super buzzy and active and running around like crazy and lifting weights and pumping iron and prepping for the next big run or whatever. I'm barely prepping for the next big walk to the bathroom. So, or to the refrigerator, or, maybe out to, I've got a long driveway. So I walk out and get the mail, but I chase my kids around the yard. But I mean, other than that, I get maybe 12, 1,500 calories, maybe 2,000 calories a day. And, shoot, man, like over the, Thanksgiving and then the day after, and then so Thursday, Friday, Saturday, I was probably pumping in, 3,000, 3,500 calories. Man, I wasn't counting. I don't really, whatever, right? But I could tell. I mean, I couldn't breathe. I felt bloated. My everything's different, even just in a couple of days' time. So, but the last few days, you're just not eating as much. I've been busier doing stuff. There's just more stuff to do. But anyway, right? You kind of waffle, but my organs aren't changing in size. All right. Now the heart, right? Like the heart is a muscle. So think of the heart as a muscle. And when the heart, like any muscle, if it's working a lot, like more than usual, maybe there's some clogging. We see, atherosclerosis or plaque buildup. We see blood pressure affected by that. We see obesity can affect the diameter, because as fat cells increase in size, the capillaries around the fat cells get stretched out, right? So it's like you put a little, a little string around the balloon, and then you blow up the balloon. Well, if you want the string to maintain the size of the balloon, you have to stretch the string, or like a piece of elastic or a rubber band. It's got to keep stretching. Well, as we stretch that tube, the diameter is going to shrink. And so distal shrinkage of vascular diameter distal to the heart means the heart has to pump a little bit harder. So hearts work harder when we're dealing with obesity. All right, you don't necessarily think of someone who's obese as, having a heart that's doing much, but the strength, the contractions. So they may not have a heart rate that's higher than 60 or 80 or 100 beats per minute, but it's the strength of contraction that is what's building that heart muscle. And it could actually enlarge. It could get an enlarged heart not from exercise or cardiovascular workouts, but from obesity or other cardiovascular issues. Yep. Oh, my stomach grows in. Right. That's the other thing too, guys. You have hollow organs and solid organs. So, like the stomach would be a hollow organ, right? Well, the whole digestive tract is hollow organs, whereas the liver, the kidneys, the heart, those would be solid organs. So, hollow organs have the ability to grow and just distend because of the type of because of what's going on with them, right? The types of tissue, epithelium, and et cetera. Whereas, the heart as a muscle would have to be working. It'd have to be, pumping iron in essence to get larger. So what would cause it to beat stronger, to work harder? Well, certainly exercise, but also obesity and other metabolic issues. So let's see. Da, 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 da. All right. So bladders, again, obvious differences in bladders. Certainly what's near and around the bladder. We do see something else kind of as we leave the bladder. We see a prostate gland with male and no prostate gland with females. Now, this prostate gland doesn't show it here, but you could see the testes. Well, you can't see the testes either. They don't show them because we're not doing reproductive. But on Thursday, we'll see a similar image or a similar illustration that's going to show the vas deferens, or the, kind of coming up and going through the prostate. So the prostate gland is kind of the junction of where we see the urethra and then the vas deferens. So anyway, that's kind of a hot spot right there for traffic. So we'll look at the prostate gland in a little more detail on Thursday. It does help a little bit, certainly with stopping the flow of urine. So males do have a little bit. Again, do they have larger bladders? Maybe, but they definitely, relative compared to women or compared to females, do males have larger bladders? I don't know, maybe, but they do have a prostate, and the prostate will enable some extra, I guess, control of the bladder. And so the urge to urinate with a male can oftentimes be kind of set aside, and then it'll kind of crop up again, and you know, set it aside. Whereas females, generally, the urge to urinate, um, you could set it aside for a little while, but it's going to be back a little quicker, maybe with males. So, and you guys all know this. If most of you are females, so you know this from experience. But with road trips and different things, right? We just generally, we have to make more pit stops, not because we want to, but because we need to, for our female compatriots and companions. All right. Plus, we got to stretch our legs, right, and our back. You can't be cooped up for hours on end and behind a wheel. Even though we're all about how many miles can we go. Leave at this time. We get there at this time. We go X miles per hour. That's the math. That's that left brain dude stuff that wants to just go and get there. But yeah, it's healthier not to do that. I mean, it's healthier to stop, and that's why we need females to keep us from being crazy, because sometimes we can get crazy with the driving and the directions and stuff like that. Well, now with no excuse with phones, right? But anyway, the prostate gland. Okay. The other thing big that we notice here is the length of the urethra. Female urethra. This we could actually say female male. This is maybe one of the few times where we can say pretty much definitively that normal male urethra, normal female urethra are quite a bit different in length. So, 6 centimeters, maybe three to 6 centimeters. So you're talking, maybe an inch to 2 inches from the end of the urinary bladder to the exit of the body. With male, it can be anywhere from 18 to 22 centimeters. So inches, so it's like 8 to 10 inches, 12. I mean, so it's a lot longer distance for urethra in a male than a female. And again, these numbers vary as well, right? That comes into play. So now we'll do our quick kind of UTI talk. So UTIs are more frequent in females than males, and part of the reason is because of the proximity to the outside world, and between the urethra and then the urinary bladder, and hopefully not all the way into the ureters. Hopefully the infection doesn't happen, but if it does, hopefully it's contained in the bladder and we can get rid of it. Okay, so this short distance does play a role. Because of the longer distance in the urethra, for males, it may take, there's more time for our bodies to fight potential infection, but it still doesn't mean males don't get UTIs. They certainly do. Now, when we have a bladder infection or a urinary tract infection, the usual suspect for the bacteria is going to be E. coli. So we want to be aware of that with our patients and certainly with ourselves. But with patients who do have UTIs, it's important to discuss hygiene because again, if it is E. coli, if it's just an acute infection, We want to make sure that they're aware of hygiene. We want to make sure they're aware of not just wiping hygiene, but sexual hygiene as well, because again, you don't want E. coli naturally lives in your colon and your rectum. So I'm not, we're just putting two and two together. Things a lot of mathematics come in, and sometimes the math is real simple. 2 + 2. So we need to discuss with the patient sometimes, especially if it's becomes a chronic issue of UTIs. So UTIs, bacteria love sugars. So we want to, we've seen in our clinics that high sugar diets, soda drinks, sugar beverages, sugary drinks, coupled with hygiene, coupled with sex stuff, coupled with any number of other pH imbalances, all can lead to UTIs. So probiotics are a big deal. Any bacterial infection is due to your normal flora being outnumbered by those opportunistic transients. So if E. coli happens to make its way over into the reproductive or urinary area, that's not good. It can lead to burning and a lot of other stuff. So when we do, I've had chronic, not me, I haven't had, thankfully never, but I've had patients with chronic UTIs that have been determined that hygiene is fine, even their diet might be a little off, but we end up seeing that they have some problems with the colon. They have fecal impaction or diverticulosis that's also chronic. And so remember the connective tissue and the peritoneum that links all of your abdominal viscera also links up with the ureters. So there's blood, So anyway, E. coli can travel. So internal, we usually think of external issues with UTIs, in particular E. coli infections, but we also see some of these occurring from inside as well. So, all right. Oh, it's prostate. Thank you, Craig. Yes. So excellent. Clinically speaking, we know from a male. So males generally, a couple of things. A healthy male should be able to go get in a car, drive a couple hours, 3 4 hours. I mean, unless they're guzzling caffeine, right? Or alcohol. Hopefully you're not driving if you're guzzling alcohol, or maybe you're riding, but even then, well, but short of a bunch of caffeine and alcohol, right? We shouldn't have to stop all that frequently. So that's a sign, right? If the urge to urinate is increasing with males, which we kind of see with age, partly because of the prostate. Now, the other thing, and so I'll come back to that. The other thing about a prostate uh, kind of symptom or issue is if the male, basically when a male has to urinate, females too, when either of us urinate, the idea is there's an inner sphincter kind of at the base of the bladder. That's the first sphincter to relax, and then you get kind of this domino effect or ripple effect of sphincters opening and including the prostate gland. So what we should have, as soon as that first sphincter goes, we should have a steady stream of urine flow. And I know, like, and it shouldn't. And when you have the urge to urinate, you should be able to urinate. So if you have the urge to urinate and you relax and you sit and you barely get anything to come out, that's a sign of a prostate problem. Another one is spurting urine instead of a steady flow. So you'd have like a psh, psh. Oh man, hold up. Oh, I got a visual. I don't have to use my mouth. So here's what you have. Here's normal. Here's a normal urine. All right. With a prostate, you'd have spurt, kind of like the end, right? At the end of, I don't know if you heard any of that visual aid. I'm not going to move my microphone closer, but anyway, yeah, if you have, kind of like at the very end of peeing, like you got to go pee, like, and you're peeing and you're peeing and you're peeing. And then at the very end, there's like, and then a little bit more, and then you're done, right? So with an enlarged prostate, the whole experience might be psh, 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 just stop, start. Or like I said, the urge to go and then you can't go. And then you sit and you're like, oh man, that's all big major signs of prostate. They call it BPH, benign prostatic, not prostatic, like relates to the prostate. Benign means it's encapsulated. The H, so it's the BPH is hypertrophy, means it's enlarged. So it's a fancy word. BPH is fancy for an enlarged prostate. Yeah, old men. Yep. First thing for tone. Yes, sir. Turns a 7 hour. I know. It turns yep. My dad, he's got type 2 diabetes. He's got some prostate issues. He's got some other things going on down there. And we live like a half hour away. And he leaves he pees, gets in his car, comes up here. First thing he does when he gets up here is goes pee. And it's like, geez Louise, dude. So, but anyway, 60, yeah, that's about that age. That's when things kind of start trickling, pardon the pun, but that's when things start trickling instead of streaming. Yeah, is right around 60, sometimes earlier in men, but they say increasing tomato products is supposed to be really good eating. So anyway, but yeah, DRE. So that's the other thing doc might do is do a digital rectal exam, and you could see the proximity of the prostate to the rectum. So if this prostate is enlarged, it's certainly going to be pushing a little. It's going to be easier to palpate for one, but the other thing is too, the prostate it's not real bumpy. It doesn't have a lot of relief to it. So when you do a DRE and you palpate the prostate, it shouldn't be like you're palpating, like at the Dollar Tree, they've got those bouncy balls with spikes all over them. Yeah, you shouldn't feel something like that in there. You should feel something more like you're running your hand over maybe like a golf ball, tennis ball, baseball type thing. I don't know. Golf ball's a little hard, so maybe not. Maybe like a tennis ball. Take a PAP any day over a DRE. I don't know. I'm 45 and I've had one prostate check. And that's enough. No one is right. I'd rather live in ignorance. Well, I know ignorance is bliss and DREs are not. So, yeah. Well, here's the way I look at it. The way the prostate works is it's pretty cut and dry. So it's not like a sign. It's not something that, just every day of your life, you're peeing normally. You go to bed, you wake up, and now you're peeing abnormally. There's usually going to be some early indicators kind of leading up to it. Like, for one, like, man, I kind of have the urge to pee a little bit more often, or I kind of go pee and it kind of spurts, or, I don't need somebody to stick their finger in my ass to tell me I've got a prostate problem if I can check all those other boxes, right? I think that's, well, they don't stick one, they usually stick two. I don't know. I don't even want to know. So anyway, well, hey, it's the holidays, right? Or yep, happy holidays. So, yeah. Well, like I say, I enjoy this. Hey, it's real world, man. Right? This isn't. We're not trying to. That's barbaric, right? Well, again, we're not trying to. Sugar. We don't want to sugarcoat anything, or poop coat or chocolate coat it. Well, anyway, um, I grew up on the farm, so I was seeing cattle artificially inseminated and weird. I mean, when you grow up on farms, you see the stuff they do to animals in the name of reproduction. Yeah. Uh, that's why I'm not. That's why I don't live on the farm anymore. Yeah. As soon as I hit 18, out the door. I'm going to college. I'm gonna be anything but that. So yeah, physical therapy was appealing, athletic training, and then it just blew up from there, thankfully, because yeah. Uh, yeah, yeah, don't go. Yeah, yep, yep. Katie had a doctor one time and it was during our second child, during Hannah. Hannah's our younger one. So Hannah was like barely 3 months in the womb. Katie was pretty much in her first trimester, and they want to do you know pap smear. Look, they want to look down there, do a pap smear. I get it, but one's good, right? Well, yeah, this doctor, it's like every time, so two more times she wanted to do a pap smear each time. Katie's like, or not a pap smear, just a an exam, pelvic exam, not a pap smear. They did one pap smear, but then she wanted to do a pelvic exam every subsequent visit to check, and we'd been one of our first rodeos. Kay's like, this is bizarre. Like, I'm not. So I said, no more. So we went to a different doctor. Nothing. It was all just, hey, how you doing? Oh, good. All right, good. Well, let us know. Blah blah blah. Not all right. Take your clothes off and put your legs in the stirrups. I'll be back in a minute. It's like, really, again? Like, you were just in there like a week ago. I, you know, you're in there more than I am. Hit it, So anyway, which isn't true, but uh, we should, boy, Thursday is going to be a treat. We haven't even, that's Birds and Bees Day. We have, and not Burt's Bees, Birds and the Bees on Thursday. So hopefully you don't miss out. Well, it'll be recorded, so you can watch it at your leisure. But anyway, we better move on, or we're never gonna get out. It'll be Thursday, and we'll still be in here talking about this. So I'll just move on from that. Yep, you've seen that urethra. Oh, here we go. Micturition. So bladder volume increases. You're going to start getting these micturition contractions, they're called. So in essence, you're going to start. So micturition is kind of the fancy word for getting ready to urinate. So urination, so creation, storage, elimination of urine, that's all kind of falls under that micturition umbrella. So again, that first, the urinary bladder is full of nerve. So as soon as that balloon starts getting a little bit bigger, you're going to get signals sent to the brain. Okay. So anyhow, so internal sphincter, then the external sphincter, then urine leaves. All right, so we're almost done. Actually, believe it or not, I know you guys are having fun. I am too, by the way. So our last stop anatomically is going to be the smallest functional unit of kidneys, and these are called nephrons. So when we kind of reverse it from tonight, we had kidneys, ureters, bladder, and then urethra, right? All right, and then we sliced the kidney open. We looked at a couple of items. We looked at the cortex area, then it didn't really do much there. And then we looked at the medulla. Oh, I know what we have to do before we do nephrons. Yeah, almost got ahead of myself. We gotta go back to this one real quick. So, so anyway, we did cortex, and we looked at the kind of the pathway of urine formation in that medullary region. So we saw the pyramids into the calyces into the pelvis. All right, so now we're almost to nephron. We're not quite there. We still have to do this little discussion on blood. So we've got blood coming in. We know that through the renal artery. Now, once the renal artery is inside, it goes past that hilum, and we're now kind of getting ready to start branching into smaller arteries. The first group is called the segmental arteries. So renal artery comes in, and then we get segments or branches. All right, so then each of these segmental arteries become what we call lobar. Lobar just means like a lobe, like an earlobe. Okay, so we've got these lobar. You know, my wife, it's my wife has a low bar, obviously. But anyway, lobar arteries are going to go in between the lobes. So then they break up into what we call interlobar arteries. Okay, so segments, lobar, interlobar, and then we curve up and call these arcuate. So these are arched arteries. And then these little guys are going to branch into finally what we call interlobular. So there's an extra syllable, right? So, that's a lot of action. Do you need to know these the path of blood flow from renal artery all the way to the neph? So then what's the interlobular do? It's basically going to become an arteriole and dump into the nephron. So from renal artery all the way up to the nephrons, that's a lot of different names of arteries. Hell, that's practically, mean, I don't even know if I needed you to name that many arteries in the whole body. So, not really, I don't know, whatever. I mean, if you know renal artery feeds the kidneys blood, and then there's a bunch of branches till we finally get up to the nephron, you're probably doing pretty good. But yeah, segmental, lobar, interlobar, and then the arch or the arcuate, and then the lobular or interlobular. All right, so I just want to show, mainly just show to, this is for effect, probably more than anything. I mean, if you're going to go into nephrology or kidney doctor's office, or you'd probably need to know the more specific ones or cardiovascular work. But for now, I mean, if you saw the word arcuate, it looks like the word arc, like an arch. So that's kind of the clue there. Lobular, right? Inter means between. Interlobular is anything that's ular or L or Ule or IOLE, right? Anything with that stuff at the end means little whatever. So if you're asked something, so my point is, if you're to see like on an exam something about comparing like a lobar, an interlobar, and an interlobular, which of the following is the smallest of the group, or which is the last one before we dump into an arteriole to a nephron, okay, or which of these is most closely linked with a nephron, okay, you're going after the smallest one, so that's that lobular. So you see that extra kind of syllable in there. Okay, you guys good? We're ready, right? Nephron time. We're almost done, I promise. Unless you guys keep distracting me, then we'll be here longer. All right, good. All right, so nephrons. All right, we made it. So now we're back in. We go back. We're kind of backing up to. So now this is the cortical area or the cortex. So medullary we already did, right? We did the pyramids and the calyces, etc. So now we're going to go back. We didn't really talk about the cortex. We said, yeah, there's a lot of blood vessels up there. This is now where the nephron is. So now it gets even more specific regarding the formation of urine. All right, so that's where we're going. Okay. All right, almost there. Oh, all right, a nephron. The nephron is the smallest functional unit. There are millions of nephrons in each kidney. We're going to see two major regions or primary regions of a nephron. One region is called the corpuscle, and the other is called the tubule. So a corpuscle is kind of like a pocket, and a tubule is just like it sounds, a small tube. So we've kind of got like a little bundle and a little pocket with a small tube coming off of it. All right, so that's the nephron. So the first part we'll look at is the corpuscular part or the renal corpuscle. This is where that interlobular artery is going to be heading toward the nephron. And remember, an artery, before it gets to a capillary, is going to be an arteriole. So we can imagine that we're going to see the term arteriole coming up. Now, the other thing I want to emphasize again is that when we're finally at what we call the functional unit. So what that means is we're at the smallest level, the smallest functional level of the kidney. And so when we go back and look at, well, what were the functions of the kidneys? Well, we said filtration of blood, elimination of waste and blah, blah, blah. We saw blood and plasma, fluid balance, all of that was in there. So the fact that we see something to do with the blood and removing, absorbing, removing, secreting any of these things, if there's something going on into the blood or out of the blood, remember we have to have capillaries. Okay, so if there's one thing out of this entire semester that I've said this before, I hope the hell there's more than one thing you'll remember from the semester, but uh there's a lot. I know capillaries are where we get anything into or out of the bloodstream. So my point is, all of next semester, physiology, 14, 15 weeks of physiology is going to be focused really on the cellular level and what goes on at the cellular level. Okay. Well, how do we get anything to the cellular level? We have to do it through the bloodstream. And where does that occur? Only at a capillary. So really, next semester, we spend the bulk of our time at the capillary network, the tissue level, and the cellular level. So we've seen it a little bit with the alveoli, right? We're dropping off CO2, picking up oxygen. These alveoli are covered in capillaries, right? So this isn't new. We saw this with digestion last week. In the small intestines, we're absorbing nutrients, right? We got to get carbs, proteins, and fats delivered to the cells. We got to get it into the bloodstream. All right, well, how do we do all of that? We need capillaries. So no different here with the nephrons. With the kidneys as a whole, we're going to see a lot of capillaries. And the capillaries are so unusual and so specific to what they're doing that they even get a special name. Okay, and this is the name. It's called the glomerulus. Okay, glomerulus. There's a little glitching going on there. There we go. The glomerulus. That is simply the capillary network of the kidneys. Okay, and the glomerulus is going to be a part of the nephron. It's really the first stop at of the nephron. So as we're bringing blood into the kidneys and ultimately working it all the way to that cortical area and into the nephron, it's the glomerulus that's the capillary network. Okay. And that capillary network is going to be fed by an arteriole, right? So that interlobular artery is going to break off into an arteriole, and then we're going to go into the glomerulus. Glomerulus is simply the name for the capillary networks within the kidneys. Okay. It's almost like kind of like the alveolar capillaries. These are the kidney, urinary, nephritic capillaries, I guess. I don't know. All right, the glomerulus. And it's surrounded by a capsule called the Bowman's capsule or the glomerular capsule. So here's kind of what this is going to look like. We can see we've got this big network of capillaries, of blood vessels, and then we've got this capsule surrounding it. Okay, this is the renal corpuscle, this little section, this little ball right there. So the renal corpuscle is simply the glomerulus and the Bowman's capsule, or the glomerular capsule. Like I said earlier in the semester, kind of throughout, they're trying to get rid of proper names. So we don't want to give Bowman credit anymore because it doesn't help us understand anything. So if we call it the glomerular capsule, it's a lot more detailed. It's the capsule around the glomerulus, not the capsule around Bowman. Okay. Or the capsule that Bowman possesses or owns. I don't even know who Bowman is, but I do know glomerular must deal with the glomerulus, and I know what the glomerulus is. So if you get into the habit of that, you can't go wrong. Okay? Glomerulus surrounded by the glomerular capsule, also known as Bowman capsule. Now let me back up just a second. Here's the arteriole. Notice we've got some arrows coming in. It looks like we have two arterioles dealing with this glomerulus. And in fact, we do. So this is somewhat unusual. Normally in the body, every capillary network we've seen up to this point has been an arteriole coming in, capillary, venule going out. So arteriole goes in, capillary network, and then venule is taking blood out, right? And that's what we saw 2 weeks ago. We saw it last week with respiratory, or 2 weeks anyway. We've seen it before. So this is unusual. Okay, we've got an arteriole coming in, but we don't have a venule leaving. Why isn't this called a venule? Well, because it's going to become another capillary network. So it's another arteriole. So that's another unusual aspect of the kidneys and the nephrons is we have a double capillary bed going on here. One is called the glomerulus. That's the first one. So as we see this afferent arteriole dumping into the glomerulus, it's afferent with an A, arterial. Remember, we've seen afferent several times. We saw it with the nervous system. Afferent goes towards the central nervous system. Efferent goes away from it. So we see the same thing here. Afferent arteriole goes into the glomerulus and the glomerular capsule. The efferent arteriole leaves or goes away from the glomerulus and the glomerular capsule. Now, for right now, that may seem like you're ready for bed. You've mind's blown. You're good to go. You've heard enough new weird terminology, but sorry, you're not quite there yet, unless you already did pass out. And nighty night, sweet dreams, right? Sweet nephron dreams. Okay, so glomerulus. So what are we doing? We're bringing blood in here. What are we doing at the glomerulus? It's a capillary network, so we must be dropping something off or picking something up. But it looks to me like there's a lot of red there, so we're probably dropping stuff off. Usually blue is where we would see things getting picked up. But yeah, regardless, what we're seeing primarily is dropping some stuff off in the glomerulus. We're dropping that stuff off into the tubular system. Now, the glomerulus is where we get our first real function of the kidney, and that's filtration. Okay, so we've going all the way back to the beginning of the night. We said, oh, the kidneys do this, they filter stuff, they regulate pH, and okay, so filtration, that's that. So physiologically speaking, this is number one thing to know. Filtration occurs first, and it occurs in the glomerulus with the glomerular capsule. Okay, so this is their first stop for doing something with the plasma. So we're going to filter the plasma. So plasma is going to enter into this tubular system. Okay, certainly a lot of us is going to stay in the blood. Now, next semester, we'll talk about hydrostatic pressure or blood pressure. We'll talk about osmotic pressure. So pressure of flow is what's enabling all of this to occur. So we'll also, the first unit next semester is on cellular transport mechanisms. Woohoo, right? So diffusion, osmosis, active transport, filtration we'll talk about as well. So when we get to filtration, week 1, week 2 next semester, we're going to kind of go back through and talk about it as it relates to glomerular filtration. In fact, we'll look at something called glomerular filtration rate. That's simply how rate is how much in a period of time, right? So milliliters per minute or something like that. So glomerular filtration rate. How much are we? How well are the glomeruli working? Okay. How well are our nephrons working? Yeah. So, and again, that's more physiology. GFR, we call it, glomerular filtration rate. So don't worry about that for right now. But do know right now that filtration does occur at the glomerulus. Now, so now what we do is kind of move. So we're forming urine. So now we've got plasma inside of this tube network, and then we still have blood inside of this capillary network. Notice the afferent arterial goes in, the efferent arterial leaves, and we see the efferent arterial is going to branch down and go around these tubes. So this tells us something big, again, that we see capillaries. Capillaries mean exchange of something is probably going on. We're getting something into or out of the blood, right? Bloodstream is being affected when we see capillaries involved. So capillary up here called glomerulus, capillaries down here called P-E-R-I, around tubular, peritubular capillaries. So what this implies, just by looking at it, you already know that capillaries are where things go in or out of the blood. We can assume things must be going in or out of the blood here as well. Good assumption. All right. So we've got capillary up here, dump some of that plasma and some of that filtrate. It's going to be urine into the tubular system. So now we start the tubular system. This would be called the proximal convoluted tubule, or the PCT, proximal convoluted tubule. Proximal meaning it's closest to the glomerular capsule. Okay? Convoluted means it's got a lot of twists and turns. Tubule means it's a little tube. Okay, so there's urine in there. Now, what if there were some items that were filtered out of the bloodstream and into the tubular system that maybe I didn't want to leave the bloodstream? Maybe I want some of the items to, maybe there's some water, maybe I need to reabsorb some things. So this is number 2, filtration's first. Reabsorption is second. So reabsorption can occur really anywhere along the tubular network. But at this proximal convoluted tubule, if there's anything that needs to go back into the bloodstream, reabsorption, this is, we can do that. Okay. So anyhow, we're going to continue moving the urine down through the tubes. We're going to go down what we call a loop, dipsy doodle, the loop of Henle. Now, this loop of Henle, guys, right in here, this oftentimes is going to dip down into the medullary area. So the bulk of what we're seeing with the nephron is going to be cortical, or in the cortex of the kidney. There are we do see the loop of Henle kind of dip down into the medullary aspects, which is where we saw the renal pyramids. All right. So anyway, so loop of Henle, so proximal convoluted tubule, loop of Henle into the distal convoluted tubule. Okay. And then again, notice we've got capillary all over the place. So we have a third thing that could happen. Notice we filtered the blood, okay, the urine and plasma, dirty plasma, whatever, what's going to be urine is in here, but there might be stuff we want back in the blood so we can reabsorb it. Okay. Well, what if there's stuff in the blood that didn't get pulled out in the filtering section, but I really don't want it in the blood? And since I'm still here, can I go ahead and put some of that into the urinary tubular system? So can I pull some stuff out of the blood that maybe didn't get pulled out up here? The answer is yes, and that's called secretion. So we can do secretion as well. That means so urine formation is going to come from filtration as well as secretion. Those are two ways to get things out of the blood into the urinary system. Reabsorption pulls things out of the urine and puts them back into the blood. That's as much physiology as you're getting. We're almost done for the night. We've almost tracked and traced where urine is formed. We haven't really done much with how. That's good. We will next semester. Where urine is formed and how it gets all the way out of the body. We started with the big scale stuff, worked our way down to the small scale. So distal convoluted tubule, we have our last kind of ditch spot right in here. Okay. As we're leaving the tubular system, leaving the nephron, heading ultimately down into the minor calyx, okay, well, ultimately into the toilet, but distal convoluted tubule is kind of the last area where we could maybe get some secretion or reabsorption to occur. So if there's still something in the blood that's got to come out, this is the last spot I could do it. If there's something in the blood or in the tubular system that I need to go back into the blood, I can do that here as well. Now, when we talk about the specifics of what is he talking about? Stuff into the blood, stuff out of the blood. Don't worry about that right now. I'm talking about ions primarily. Okay, I'm talking about electrolytes and sodium, potassium, chloride ions, hydrogen ions, bicarbonate ions. That's primarily the stuff. I'm also talking about nitrogenous waste, right? Ammonia, urea. Hey, that stuff we want that to stay. So if I've got a ton of nitrogenous waste coming into the hopper, right? Nitrogenous waste delivery coming to the glomerulus, we drop it off. Okay, so we've got all this ammonia and urea, and then the blood leaves the glomerulus, and we get out here and the system says, wait a minute, we still have a lot of nitrogenous waste. Can we still get it into the urine? Yeah, yep. We don't have to go back to the glomerulus. We can do it through this paratubular network and dump whatever else that maybe needed to leave that didn't get pulled out in the filtration process. That's all a mouthful. It's a lot of info, but We're almost there. We almost made it. You can see a term that's familiar down here, calyx. So anyway, the distal convoluted tubule is going to dump all of that filtrate, which we call urine, into the collecting duct. Okay, and then the collecting ducts are going to be contained within the renal pyramids, and then those pyramids are going to dump then into the calyx and minor calyx, major calyx, renal pelvis, ureter, urinary bladder, urethra, and out. So that's from bloodstream, from plasma, from bloodstream, some nitrogenous waste, some ions, some stuff I just don't want. I need to get rid of it. Okay, we enter through the afferent arteriole into the glomerulus. Okay, and then that filtrate is going to continue through the glomerulus, from the glomerulus through the glomerular capsule into that proximal convoluted tubule, down the loop of Henle, up the loop of Henle to the distal convoluted tubule, out to the collecting ducts, into the renal pyramids, into the minor calyx, major calyx, renal pelvis, ureter, bladder, urethra. So that's the pathway of urine formation. So I don't expect you to have this etched in at all. I do expect you to have I have no expectations, to be honest. Right? Expectations are funny, aren't they? Expectations can set you up for disappointment, and I don't ever want to feel disappointment because of expectations that I have on you. So I guess that's not the right word. Really, my goal is to introduce you to some terminology that we're going to go deeper with next semester. So when we do get there next semester and dig deeper into how homeostasis occurs, how in the heck do we maintain pH and electrolyte and fluid balance? How in the heck are we able to function for 70, 80, 90, 100 years? Hell, how are we able to function a minute, let alone that many years? So generally with, hopefully with minimal pain, with minimal stress, with hopefully. So anyway, next semester digs deep into all of that. So I will revisit this illustration here. I'm not just going to start talking about glomerular filtration rate and all this other stuff without reminding you of what the heck a glomerulus is. But it shouldn't be reinventing the wheel. So anyway, that's really the goal of this whole course, and certainly then that was our goal tonight, is to just introduce you to the very basics of the urinary system. And it's not basic at all. It's probably one of the most physiologically complex systems in the body. It deals with a lot of oddball pressures, anyway, there's a lot of action. So just introducing you to a nephron, and then to the little bigger picture of the gross anatomy of the kidney, and then to the bigger picture of the whole urinary tract, and then ultimately the entire urinary system. So if you guys have questions, they may not pop up today, they may not even pop up tomorrow, but you certainly can email me anytime you want. I'll see you guys Thursday. We're going to be playing around with Unit 9. We'll be looking at Unit 9 portfolio a little bit, and looking at the birds and the bees. And other than that, I don't have much else for this evening's course or this evening's info.